Next presenter is Dr. Diman Banik
from National Heart Foundation.
He is from National Heart Foundation. He is a renowned interventional cardiologist. I am requesting Dr. Diman Banik to present his topics. Patient preparation for intervention. Dr. Diman Banik from National Heart Foundation.
Yes, can you hear me?
Yes.
Yes. I am really thankful and grateful to the organizers of BSCI for giving me the opportunity to speak on this August gathering. Today my presentation is on patient preparation for intervention. Honored chairpersons, moderators, panelists, learned fellows, and learned colleagues. Cathlab procedure seems to be simple, but in any term, it may turn over into an ugly events at any moment. So all the persons involved in the Cathlab should be on foot, as in war, in Cathlab doing the procedure or outside the Cathlab. The Cathlab personals are primary operators. It is a physician, secondary operators, and the medical officer is also the physician, nurse supervisor, Cathlab nurse, and the technologist. Some checkpoints, checklist I will mention later on. We should recheck about the blood sugar of the patient, about taking the dual antiplatelet, doing a coronary angiogram, IV fluids, mainly patients with hemodynamic instability, whether the patient is on inotrope support, whether a patient with creatinine, high creatinine, having hydration with fluids, and the sedation and pre-medication during the Cathlab procedure in the early morning or in the during the pre-procedure, and explain the patients and the relatives of the procedure briefly should be done by the Cathlab team. Some important checklists should be identified previously before putting the patient into the Cathlab. These are the patient identification, and the written consent should be taken, and some important clinical status should be well noted about the temperature of the patient, whether the patient is on normal temperature. The ejection fraction is an important issue. You should know the ejection fraction of the patient prior to putting the patient on the Cathlab table, because it will give us the guideline for using dyes and using special attention to the patient, whether the patient has features of heart failure, whether the patient is in shock, and some allergies event of the importantly of contrast allergy. And my previous learned speaker, sir, has told about the exercise plan. You should always feel the pulse of all the 4 pulses of the body, including the brachials, both the radials, both the femorals, brachial, and the dorsalis pedis artery. And next, the important is the laboratory investigations. About the laboratory investigation, electrolyte should be normal. My next learned speaker Nurul Alam will say about the reduced renal function and contrast-induced nephropathy. And I will briefly go on these important issues of the laboratory investigation. According to the WHO, in a male patient, below 13 gram per dl, and in female patient, 12 gram per dl is diagnosed to have anemia. According to WHO, 1/3 of the patients undergoing PCI had anemia. Hemoglobin less than 11 or 10.9 gram are associated with high risk of long-term ischemic events and bleeding events, and as well as mortality during and after PCI. Regarding this, it is an important slide regarding the bleeding issues of the patient, and it concircles with the 4 important things, that is platelet count, INR, anticoagulation, and antiplatelet. Antiplatelet will be later on discussed in this session also. Regarding the bleeding issues, the patient who are increased chance of bleeding and vascular complications are advanced age, female sex with high index, body mass index, patients with renal failure has high chance of bleeding, patient with acute MI as the patient is more thrombogenic, and angioplasty, recent angioplasty, and balloon IABP support is there. Other, the patient is having glycoprotein 2B and 3A receptors, thrombolytic, unfractionated heparin, or low molecular heparin before the procedure. This is the important chart often given by National Cardiovascular Data Registry, whether the patient has an increased bleeding risk. This is the slide on the left-hand side. This is the score, and if the score is more than 65, it is more chance, 6.5% chance of bleeding risk, and if the score is less than 25, it is less chance of bleeding. Strategies for the reduced bleeding are during an intervention, we do the ACT. If the patient having glycoprotein 3B and 2A receptor blocker, in addition to the heparin, then ACT should be within 200 to 250. And if glycoprotein 3B 2A receptor is not there, we are not using it, then the ACT should be on 250 to 300. ACT above 350 to 350 demonstrate a high risk of bleeding. A patient going to a radial access route, having important presentation before, radial route is the less chance of having bleeding risk. The important anticoagulations are during the procedure: unfractionated heparin, enoxaparin, fondaparinux, and vivaluridine are the anticoagulant with established efficacy in contemporary PCI practice. According to ACC-AHA guidelines, improvement in drug-eluting stent technology and using the above mentioned anticoagulants helps to minimize the bleeding and ischemic risk during the PCI. An important issue is that the bivalent molecule, vivaluridine, is the only direct thrombin inhibitor which can be used safely in patients with reduced renal function, and which will reduce the bleeding risk, and in older age patient which has more chance of bleeding. We can use vivaluridine. It is available in our country. This is the slide of giving the four anticoagulant during the intervention procedure. It is the giving bolus dose and the IV maintenance dose. Then the important is the INR. INR is the international normalized ratio. A common consensus is that angiogram and angioplasty can be done safely with an international normalized ratio INR less than 1.8. And among the atrial fibrillation patient undergoing PCI, rivaroxaban is safe than warfarin with dual antiplatelets in doing an intervention in case of bleeding risk. Then the important issue of a patient undergoing intervention are the risk stratification of the patient. Risk stratification mainly depends on increases patient having kidney disease, ejection fraction, coronary artery anatomy, diabetes, hypertension, patient having ACS, heart failure, arrhythmia, and cardiogenic shock, and having peripheral vascular disease. This is the important scores. There are very important scores which are done in different studies during the risk stratification of patient undergoing intervention. There are three types of scores. There are clinical scores and angiography scores, and combination of the both. There are four important clinical scores having in different randomized trial. These are risk model score. EuroSCORE is very important, and it is done in very important randomized trial up to now. A myoclonic score is there, and an age creatine ejection fraction score. These scores are have some defaults. That is, they are only on clinical base. They does not on the basis of angiographic findings. And there is only angiographic finding score. The two important angiographic finding score are ACC-AHA lesion classification. You all know the type A, type B, and type C, and the syntax score, which is a renowned score. But these two scores also have some difficulties in assessing the patient, as because they are only on the clinic anatomy of the coronary arteries, and they have no scores on the clinical presentation of the patient. And so the world different studies had modified these scores, and a combination of an EuroSCORE and the Syntax score, which is known as global risk score, which will be shown later on. This is the EuroSCORE, which is 17 variables. More important is the patient having septal rupture after MI, and the other important things are the patient having previous cardiac surgery. Previous CABG has an important 3, and patient having infective endocarditis having importantly having 3 points, and patient with low ejection fraction 3, and patient on cardiogenic shock, on ventilation, on preoperative intervention cardiac arrest are on the 3 score. And this score has differentiated into low risk 1 to 2 points, intermediate risk on 3 to 5, and high risk on the 6. And this is the Syntax score based on the important points. Syntax score has a high important, and this is the global score using the Syntax and the EuroSCORE. You can see that if the EuroSCORE is more than 6 and the Syntax score is more than 33, these are the very high risk patient for high risk patient. Regarding the diabetes, you all know diabetes should be controlled using on metformin, should be avoided 1 day before and on the 2 to 2 days after the intervention. As metformin causes acidosis, it increases the chance of acidosis during the intervention procedure. The chest X-ray, you should do the chest X-ray, look at the chest before doing an intervention. It will give the features of cardiomegaly, features of pulmonary edema, and other comorbidities, and also in selection of the guide catheters in seeing the aortic root. And importantly, echocardiography should be seen in patients with going to intervention, as because ejection fraction is said to be the significant prognostic indicator for an intervention, doing an intervention. Reduced ejection fraction at high prognostic significance. And if pericardial effusion is there, we should give the anticoagulants in a tapering dose, and other valvular morphology should. Important issue is that COVID infection with PCI. Every patient undergoing routine PCI should be done a COVID test. A COVID positive should be deferred temporarily. In patient, this is important in patients with ST segment elevation MI and ST segment elevation MI. If an ST segment elevation MI comes, then if there is contraindication of fibrinolysis and high risk feature, primary PCI can be done with a separate Cathlab, or the Cathlab is on the air conditioning with the HEPA filter, and the minimum personnel on the Cathlab with PPE, strong PPE, they can be done COVID-19 primary PCI. And in the it is told that in the pandemic of COVID-19 associated ACC AHA, 19% reduction in PCI procedures, which has an increased mortality of patients with ACI.
We have some questions to be asked to you.
Yes. Yes, then this is the, yes, you can ask the question. I am almost on the last slide.
Yeah, now
Okay.
discussion.
Okay, Dada.
Yes, sir.
Number one question for revascularization, how many days it should be hold before doing coronary angiogram or PCI?
Revascularization should not be stopped. It can be continued. It is said that it can be continued. It is safe than during the PCI.
If we are on metformin, when it should be stopped before intervention, and how long before it should be stopped?
It should be stopped 1 day before the intervention, and it should be continued again 2 days after, as because metformin causes acidosis, and the dye we used, it also causes acidosis. So this increase the chance of doing acidosis in patients with performing the intervention.
Dr. Diman Banik, do you use regularly low molecular heparin or conventional heparin in your ACS patients during PCI?
we do not use low molecular weight heparin. After the we use heparin bolus dose during the ACS patient, and before the day of operating, we stop the low molecular weight heparin 8 hours before the doing the intervention.
So, Dr. Diman,
Yes, sir.
and I am very much pleased to say this should be need for our fellows. But before what I can add to your lecture, mental preparation of the patient as well as his relative is very, very important for cardiovascular intervention. Patient should be mentally prepared to make the mental shape of the patient. Thank you very much.
Thank you, Dr. Diman Bonik, for your nice and time-demanding presentation.